Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork. We are live today at the Harvard Varsity Club with repeat guest and friend of the podcast, Dr. Thomas Gill. Dr. Gill.
Dr. Roth.
Welcome back.
It's great to see you.
How you been?
I'm good. I know it's only been, 18 years for us now? How long has it been?
Yes, we met when I was a sophomore or junior at Weston High.
I remember Riz and I were covering a game last night and reminiscing about the time when you were running around out there.
On a grass football field.
That's right.
That's how old you are.
Field.
How does it feel?
I feel as young as ever, and I heard you could have used... Yeah, vibrant. Weston could have used some support last night.
We could have, but we have high hopes for next year. And we still have the Whaling game, so...
Okay, good. That's right. We got to beat Wayland on Thanksgiving. You're now involved with the Boston Sports Medicine and Research Center. How's business?
It's going well. You know, I think one of the great things about sports medicine in general is there's so many things as a profession that you can pursue. So obviously clinical care, patient care, kind of it starts and ends with that, and that's always going to be my passion. But the great thing about sports medicine is it gives you so many opportunities for research, whether it's trying to prevent arthritis, trying to treat people with arthritis so they don't end up needing joint replacements, shoulder injuries, how to get them back. Now we have this big thing with bad rotator cuff tears and being able to augment them now with collagen patches and regenerative medicine. So it's a fascinating field. It's a fascinating time. And that's the great thing about Boston Sports Medicine Research Institute is we have the clinical focus, but we're still doing all the research.
So you mentioned augmentation for rotator cuff tears and massive rotator cuff tears and irreparable rotator cuff tears is a big hot topic in shoulder elbow surgery. What have you implemented into your practice specifically in terms of augmentation or biologic healing?
Sure. Well, I think, there's a couple of different philosophies now. There's a couple of different products that some look for, quote unquote, add biology. Others try to add strength at time zero. And some try to add both. So, for instance, one product's called Regeniten, and it's it doesn't add any structural support, but the goal of it is to try to thicken the tendon, make the tendon a little bit stronger, hopefully reduce the tear rate. There's another one called, say, an Arthroflex patch, which is an acellular dermal matrix. And the goal of that is if you have a poor quality tendon, you can put that in, it gives you real structural support. So hopefully, the theory being, the tendon's not going to pull out of the anchors and they pull away from the sutures, and hopefully you decrease your recurrence rate. And I've kind of moved more towards something called a BioBrace patch now, which is it adds some strength at time zero, and it adds biology down the road. And I think it's a great mix of the two because maybe if it's too much structure and not enough biology, it doesn't actually incorporate and heal fully. And we're doing a study now that's looking at some of the complications with that patch with some kind of aseptic reactions that look like infections, and it's almost like a rejection type of process. So that's led me a little bit away from that. But yeah, it's just a fascinating field, and we just need good quality studies, prospective studies to hopefully get some answers.
Now, working with a lot of the patients that you end up doing procedures on, rotator cuff repairs, and we see them in the clinic, why are we seeing an increased amount of patients that have biceps tenodesis done?
Rich Hawkins was one of my mentors in shoulder surgery, and he taught me at a very young age there are very few isolated biceps problems out there, especially when you start getting a little bit older and in athletes that are a little bit older. I remember usually it's associated with some kind of rotator cuff tear, whether it's a partial tear or a full tear. And I remember taking care of Kurt Schilling with the Red Sox. He had a biceps problem, and there was a doctor telling him, well, you just have a biceps tenodesis, you'll be fine, you'll keep throwing. And told him at the time, first of all, I don't know anyone in Major League Baseball that's still throwing and pitching with a biceps tenodesis. But secondly, I can promise you when you're a 38, 40-year-old pitcher, your biceps is not your main problem. All right, you're going to have a rotator cuff. You're going to get in there to do the biceps. You're going to end up with a rotator cuff repair, and that'll be the end of your career. So I think what Dr. Hawkins taught me was, one of the biggest reasons for a failed rotator cuff repair that went well is missed biceps pathology or missed AC joint pathology. So we always now are just much more aware of associated biceps tendonitis, partial tears, labral tears, and making sure we're treating everything at the same time so that, again, patients don't have to come back for a second surgery.
And are you diagnosing the biceps pathology on your diagnostic arthroscopy? You're looking at the biceps attachment at the superior labrum. You're following it into the groove past the transverse humeral ligament. You're looking at it and then deciding what to do then? Or do you have a pretty good idea based on physical exam and MRI?
So that's a great question. I think, and this is a topic we could spend hours on, is how much credence people place on, what's the MRI show? What's the MRI show? Even insurance companies now, you can't get approval to do a surgery on someone unless you tell them what the MRI shows. And you try to tell them, this is not an MRI diagnosis. This is called a physical exam. I put my thumb on their biceps and they say, ow, you know what? Your biceps is a problem. You have them reach out to the side, you do a speeds test. Yes, that recreates my pain. It is a history and physical exam diagnosis that's then confirmed at the time of surgery. But at the end of the day, it all comes back to the exam pre-op.
Our live episodes at the Harvard University Varsity Club are brought to you by our friends at Met1 Orthopedics. Are you looking for innovation in orthopedics? Meet the only U.S.-based Latin-owned manufacturer, now leading the way in upper and lower extremity solutions. They've just expanded their portfolio with the newly launched Fortis distal radius plating system, cleared and designed for next-level performance. This isn't just progress, it's representation, precision, and results, all in one. You mentioned that you took care of Curt Schilling with the Red Sox. You were both the team physician for the Boston Red Sox and the New England Patriots. Walk us through a typical day with both teams, the similarities and the differences.
Yeah, they could not be more different, Major League Baseball and the NFL. I mean, when I started out, I had been with the Patriots, and that was very structured, almost very corporate type of setting. You had, when you're on the road, you had scheduled meetings at 4:30, 5:15, 6:30, so all the way through. The food was all set up by a nutritionist, right? So you had your protein, your complex carbohydrates. Everything was on a schedule. You're not going out, as Bill Belichick used to say, it's a business trip. It's not just a game. Baseball, when I started out, was very, very different. You had, the food wasn't run by the clubs. And Brad was in here, the head athletic trainer for the Red Sox, and he can tell you how much it's changed. Something we instituted when we came in, we brought kind of the Patriots way to the Red Sox, which was, you had P.F. Chang's and Popeye's chicken and whatever the guys wanted because it tasted good. I'm like, how are we building muscle? How are we preventing muscle injury? How are we building strength? How are we building performance? With no offense to Popeyes. Popeyes is delicious, but still, it's not something you want to train on as a professional athlete. So we kind of came through a completely different setup, with how we're going to train the guys and train the athletes. But, baseball is an enormous amount of time with relatively little going on except for specific moments. So the guys would get to the clubhouse maybe around noon for a 7 o'clock start. I'm not really sure what they were doing the whole time, but they're doing some stretching, watching some movies. I remember having an argument between Papelbon and Schilling about who would win between a vampire and a werewolf. He said, Doc, will you please tell Papelbon that a werewolf could kill a vampire anytime? I started laughing, like, no, what? I'm serious. I said, no, you're serious?
Yeah.
He's like, yeah. I said, all right. So I knew I wasn't in Kansas anymore when I heard that. But there's a lot of time because the guys are with each other so much, and there's 162 games. So it's a very different culture. But from a team doctor standpoint, you needed about an hour and a half, 2 hours before the game, evaluate guys when they came back from a road trip, who can play, who can't play, what kind of treatments they need, working with the athletic training staff. But then once the game starts, you really weren't needed that much. Football could not be more different. A lot of the work pregame for football was during the week about who can play, who can't play, what's needed, what kind of treatments are needed. But from the time the whistle blows for football, you are needed as a team physician. And there might be 6, 7, 8 significant injuries during the course of a game that you have to make instant decisions on with the athletic training staff. Is it safe to go back to play? Are they not play? Is it a serious injury? Is it not a serious injury? Do they just need some time out for a while? Do they need imaging? So it's a vastly different practice of sports medicine between baseball and football.
We recently talked to Dr. James Andrews. Thanks to you getting us in contact with him. Tell us about your importance of what you think of high school and youth sports, and how do we develop those kids and try to reduce injuries as they start to get older?
Well, I think Andrew, first of all, Dr. Andrews is an enormous mentor and teacher for all of us in the field, and he's given back so much of his time in his career, and we owe him a huge debt of gratitude. That said, I think you're probably in as good a position as anyone else to answer that question. I mean, having had the pleasure of working with you for, what, 24 years now?
Almost 30.
With but you and I together.
Yeah.
I'm not that old. Give me a break. We're trying.
Well,
but
we'll have pitch talk later.
But there's the whole importance, I think, of youth sports and the evolution of youth sports can't be underestimated. Mm-hmm. And I know that I've learned more about concussions from you, literally, than probably anyone else in the field of sports medicine. And that's setting up the protocols that you did to monitor these kids, get them tested before the season, get them on neuropsych testing after an injury, and then doing the return to play criteria. But, the thing about sports, we were standing on the sideline last night together, it's not just the wins and the losses, but, the studies are pretty clear. When kids are involved in sports at a young age, they do better in school. They get into less trouble after school. They get more confidence. And I don't like to use the word successful, but they're more, whatever their passions are, they're more successful moving forward because of what they learned in the concept of a team, how to work within a team, a structure, an organization, how to build leadership. I'm obviously biased, but I think that it all starts with youth sports and with high school sports. Now, that being said, having had 3 kids of my own go through the whole club team youth sport program, I think we could probably dial it back a little bit. Like, I don't know that a baseball player, for instance, needs to be pitching 11, 12 months out of the year on 2 different club teams, a town team, and a high school team, mm-hmm. right? And even the Red Sox pitchers, from the end of the season in September, October, they don't pick up a ball again until January. Mm-hmm. But yet our kids aren't doing that. Why? I think youth sports have gotten a little like hockey. I mean, hockey around this area is huge, but kids need a break from time to time. Kids need a little bit of time to be kids as well. So when I was growing up, you played 3 different sports, and in the summer you had a job or you did camp or something like that. It'd be nice to have the kids get summers again. But that being said, I think youth sports can't be overstated, their importance in the development of a kid.
Was there a specific moment in your pro sports career that defined your concept on return to play for athletes?
Yeah, that's a great question, Cam. And I think that I always tell people, and when I'm trying to teach our residents and fellows, I would say, and it's kind of a life lesson too, like you got to have something you believe in. Like, what do you believe in? How do you make your decisions in life? How do you make your decisions in medicine? For me, my visual or my compass in medicine is anatomy and biomechanics and with the biology. So by anatomy, I mean biology. So what's the biologic healing process? Because a player says, hey, doc, I know you did my labral repair in my shoulder. I want to pick up a ball. I want to start pitching at 3. I feel great. And don't hold me back. Or I had my ACL done 3 months ago. It feels awesome. I mean, got my strength. I'm ready to go. You might say, sure, that's fine. If you feel up to it, you can do it. But if you know the anatomy, the biology of healing. We did a study, for instance, in rotator cuffs in sheep, in a sheep model. At 3 months after a rotator cuff repair, there's only 28% healing of the tendon to the bone. 28. So you hear about people doing the resistive exercises starting at 6 weeks, you have to say, what are we doing? Mm-hmm. So from a scientific standpoint about, guideline on return to play, you have to go back to the actual biology of healing, ligament remodeling, cartilage remodeling. And then as far as a performance standpoint, I think probably the player that taught me more, that challenged my concept of return to play more than anyone else was Teddy Bruschi. And this is all publicized. Teddy's an amazing athlete, a good friend, but he's talked about his recovery from his stroke. And I'll never forget when he had that done, we were taking care of him. I said, how is this player ever going to play football again? That just goes against everything you believe, like a contact sport, etc. But because you just have to come back to square one, get the proper imaging studies, do the proper exam, talk to all the experts, because you can't, sports medicine is unique. And one of the great things that I always found as a challenge in professional sports in particular was you can't go to the American Journal of Sports Medicine and find a prospective randomized study on 100 professional football players who had a stroke and their ability to return and how they should be treated, right? It doesn't exist. Mm-hmm. So you're kind of writing the books and writing the instructions as they go. And you have someone like Teddy who will do whatever you ask him to do, attacked his rehab like nothing I've ever seen, and is just a real role model for so many people now and has reached out to that community in an incredible way. But to see what his neurologist and neurosurgeon getting the proper consults in and you really challenges your perception that this player can't get back. I think with the right care and the proper care, people can get back safely, even after something like a stroke. And that's the great thing about our field, right? It opens new doors and prevents new challenges.
How do you manage the professional athlete stars when they're demanding to return to play, but you know it's not the right thing to do?
That's a good question, and it's got a couple of aspects to it. I think it kind of comes back to what people ask all the time. How do you handle professional athletes versus if Dr. Cam Roth came into the office with a certain project? And my answer was always simple, and it sounds a little cliche, but it's actually really was our philosophy, and why I think we're reasonably successful with what we did was these are human beings, right? Their ACL works the same way yours does. Their rotator cuff works the same way. Their brain works the same way yours does. Maybe not the same way yours does, but the same way most people's do.
Depends.
But you have to treat them as it's like Bill Belichick's sign at the locker room. Don't believe the hype. Don't read the hype. If you treat everybody the same, what's different about a professional athlete is their occupation. So if you come in and see me in my office, my care plan is going to be based in part on your occupation and the demands. So an iron worker is going to have maybe a different return to play, return to work than a computer software engineer. So we take that into account. Professional football or baseball or hockey. These athletes, men, women, they all want to get back and play, but you have to remember they're human beings first, athletes second. Their biology works the same, and you have to educate them, right? You just have to take the time to try to educate them why you're making the decisions that you are. And the good thing about being around him, this is kind of one of my things I worry about with sports medicine today in particular, is every time an athlete gets hurt, their agent gets on the phone and is shipping them across the country to go to see a physician that doesn't know who they are, doesn't know their background, doesn't know their injury history, doesn't know how they've worked out, doesn't know how they respond to injury, doesn't know them from a personal level. The psychological side, they don't understand as much. So is that good care to drop in once, get a quick procedure, come back, and then never get seen again? I don't know. So you kind of have to, with the star athletes, if they still have an issue, say, you know what, talk to some of the guys in the locker room. All right. Ask them what their experience has been like with the medical staff, the athletic training staff, and the team doctors. Understand that there's probably the person second to you that's most vested in your recovery is your athletic training and your medical staff for the team. And I think once you educate them about their problem and your investment in them as a person first and an athlete second, it usually works out pretty well.
I think it's pretty interesting. I've been a few years in practice, and you know the infection rates and you know the complication rates. However, if you operate on a high-profile person, if something bad happens, that becomes publicized. And can you imagine if your regular patients, if your complication rates or infection rates, however small, became publicized? You know that these things are going to happen. All procedures do have, complications rates, and we counsel the patient on all of these. And as you said, these are just human beings. These things can just happen to people no matter if you're the best surgeon in the world or they're the healthiest person. These things just happen, and unfortunately, that's part of the job and part of taking care of people.
But that gets back to what you asked, Cam, is about, how do you deal with the star athletes? And there was a very, very well-publicized case of an extremely well-known athlete in this town who had had a major knee injury that we had scheduled to operate on, 5 to 6 weeks down the road, because at that point they had a lot of rehab that they needed to do. There were a couple ligaments involved that we were trying to treat and heal differently. All signed up, and then the next thing you do, the next couple of days, we find out that the patient had left town and someone else had intervened in the care and said, don't wait, get your surgery right now. We're going to do it differently. We're going to change our protocol for our regular patients because of, your position. You want to get it done faster, so we're going to defer to you. And then after surgery, we're going to use some techniques and ointments and rehab techniques that maybe we wouldn't use on a regular person. That patient had major problems, infections, stiffness, could have ended their career. So I think you have to be careful about going outside. The system works. Your care plan works. Your algorithms work. Just treat them like humans first and athletes second.
You can't be scared off by the patient. I do find myself, if I'm treating a friend or a friend of a friend or even a minor league baseball player, I do find those thoughts creep into the back of my mind.
Absolutely.
What if I try something different. Oh, I just read this in, the Journal of Hand Surgery or JSES, or I just talked to this surgeon or watched this video. Should I try this? I couldn't even imagine the pressure of operating on or taking care of the people that you've operated on, and having those thoughts creep in the back of your head as well.
But I think that you're a good enough surgeon and you're incredibly accomplished. You're not going to go try that operation until you've been to the lab and you've done it on the cadaver lab and you've done read the research and you've practiced it before, and you're going to go work with Riz, who does that procedure a lot, and you're going to learn from. You're going to do it the right way, and then you're going to bring good new technology. Like, that's one of the things that sports medicine's taught me in my career. I'm not doing things the same way now that I did before, because I've learned both through our research, through going to meetings, through some of the committees and societies that we're involved with. Hey, this is good, but this actually has an opportunity to be better. And when you study it properly, I mean, that's the great thing about our field is it's like golf. You can always be better. You never are going to master golf. You're never going to master surgery. You can always get better.
So we were just talking to a guest before you came on, Isaiah Kazavinsky, who you know is a friend of mine, friend of the show. And we talked about when you have that conversation about retirement. So dealing with pro athletes in your career and athletes at another level lower, called collegiate athletes, when do you have that conversation, and how does that conversation start if someone comes into you for their second, third, fourth knee surgery? You say, listen, I think it's probably about time we have a conversation about you maybe stepping away from sports. How do you start the conversation, and what have you found has worked best to make sure that you're giving the right message to them so they don't think that you're not looking out for their best interest?
So it comes down to two different things. There's the medical answer, right? And then there's the personal answer. And a lot of it depends on what your relationship is with that player. I remember with Rodney Harrison, there's a guy that I took care of for a long time and operated on some major injuries. Incredible person, incredible athlete. It's hard to make them better than Rodney. But we had that conversation after one of his injuries, but we could because we had that relationship, right? I think from a medical standpoint, I'll sit down and say for an athlete, if they've got a lot of articular cartilage damage, maybe they've had a revision ACL reconstruction, say, look, you're 31 years old, you got two young kids. I can get it so you can play. It's your decision. Is it worth playing? Can you still play at the level that you need to play at? Can you still play at the level that you want to play at? Take the big picture into account. And I think there's no diagnosis that's a bigger issue than with concussions, right? No one knows better than you. It's if someone starts racking up the number of concussions, at some point, what does the rest of their life, their family life, their personal life look like? And you're not there to make that decision for them. I view my role as just a sounding board. Mm-hmm. And I'm there to help. Ask me a medical question. I can tell you what the natural history of the problem is medically, but then let me try to at least help if I have that relationship with you. Let's just put it in context. I'm not here to tell them what to do, but just to make them think and ask them open-ended questions that then they can go back to their family and their advisors to make that decision on their own.
Lightning round.
So, lightning round for Dr. Thomas Gill. What's the worst advice you hear athletes getting?
Worst advice. Two worst advice. One is, I got this great supplement for you. It's going to solve everything. You take this, you don't even need to work out. Right? You take this pill, you take this, whatever, it's going to be great. And you're going to be stronger, better, faster, stronger. And half the stuff is either banned or has terrible side effects. Yeah. So first is, take this, you'll do great, right?
Just scroll the Instagram, you'll find it.
Yeah, right. Click on the Instagram ad.
One exercise you'd love your athletes to master.
It's something that nobody ever wants to do, and that's core strengthening, right? Everyone's like, my knee hurts, I'm going to get giant quads, or I'm going to get giant arms, and then I'm going to be able to strengthen. But it all comes down, if you have a strong core, you're going to prevent a lot of injuries, you're going to help performance.
Before a patient sees you in the office, what is one thing you wish they did before they talk to you?
Well, I can tell you one thing I wish they didn't do was Google it.
Yeah, okay. Agreed.
I think before I see a physician, I actually do a little background check on them and kind of what their experience has been like. Because I think if people get to know who you are and maybe what you have done and the type of surgeon you are and maybe the quality of the care you try to give, I think it helps streamline the recommendations you're going to give a lot later, and they can put a lot more trust in you and what you're doing. So probably research you a little bit before they come to see you, and then I think there's a lot less consternation and a lot less concern, because it's a complicated time. You're hurt. You're not feeling great about your life, yourself. You're nervous. It just gives you a little bit of peace of mind.
Ice bath, heat, neither.
Personally, I'll take both. I heard about this concept of a mobile cold plunge. It actually sounded quite interesting, but I'm a heat before ice after guy.
Makes sense.
Good?
I think we're good.
We're good.
Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.